Hello, welcome back to Oral Surgery Journal Club. If you're joining me here, we're going to get into a full-length discussion of the AAOMS position paper on MRONJ. Now, of course, this is the 2022 update that just recently came out, and there's a lot to talk about, so I hope you'll bear with me. We'll get into all the nitty-gritty and the details, and of course, at the very end, I'll leave you with some of my own thoughts and my own 2 cents. Let's start off with the authors. There's 6 different authors. AAOMS put together a committee, so 3 of the authors are from the committee, and the other 3 authors were from the previous position paper. Now, of course, MRONJ is a developing field, right? It's relatively new, and as we learn more, we're developing, accumulating more and more data. And of course, AAOMS's job is to continually put out new guidelines to reflect the new data and our better understanding of what MRONJ is. Now, not everything in this position paper is necessarily new. Where it is new, we'll talk about that, but of course, there's a lot to repeat from old, and I think it's worthwhile just to repeat just for understanding. So they start off with the background where they discuss what it is. Moving forward, they're going to talk about anti-resorptive medications, and within that category of anti-resorptive medications, they're referring to both bisphosphonate medications as well as denosumab, which is a rank ligand inhibitor, rank L inhibitor. So both of those medications together form the category of anti-resorptive medications, and anti-resorptive medications are used both to treat cancers, bone cancers, multiple myeloma, as well as to treat osteopenia and osteoporosis to prevent skeletal events and to prevent fractures. Now, bisphosphonates come in oral forms as well as IV forms, and here's some of the names. It's definitely worthwhile to be familiar with some of the names, so when you discuss it with your patients, when you try to elicit your medical history from your patients, they may not be familiar with the term bisphosphonates, but they may know the specific drug that they're on. So they may be on Reclast or Boniva or Fosamax. Those are some of the more common ones. And when it comes to denosumab, it comes the generic names. Sorry, the trade names are Prolia and Xgeva. So those are names that patients may be familiar with. Definitely worthwhile to be familiar with the trade names. All right, so let's start off with the MRONJ case definition. Now, of course, we need a definition, and this hasn't changed. So the definition requires 3 criteria. You need a patient to have been exposed to anti-resorptive medications, obviously, so that's number 1. They have to have a history of being exposed to those medications. 2, you need exposed bone or bone that can be probed through a fistula, so essentially just exposed bone. And it has to persist for 8 weeks. That's important. If it just goes away on its own, then of course it wouldn't even qualify as MRONJ. And lastly, there has to be no history of radiation. And that's important because that would exclude osteoradionecrosis, ORN. Even though MRONJ and ORN look the same, of course we want to differentiate them because mechanistically they are different. So staging. Now staging is interesting, and this can trip people up, so let's go through it carefully. Stage 0. What's interesting about stage 0, it's even interesting at all that they have a stage 0, but what's interesting about stage 0 is patients do have symptoms, very nonspecific, vague symptoms, but they have something, but they do not have exposed bone. So basically, patients will present with like dental pain, but it's not explained by any dental cause. You have this vague symptoms of pain. Radiographically, again, there's not much on the radiograph. It's very vague trabecular pattern changes, but certainly nothing that would really look like frank osteomyelitis, nothing that would look like osteoradionecrosis, and you have no exposed bone. So you just have very vague symptoms that you can't attribute to something else, and we call that stage 0. Once you get to stage 1, what's interesting, I find this, and it's a little hard to keep straight, stage 1, the symptoms go away. So stage 0, they had symptoms, but you didn't really have much else besides vague symptoms. There wasn't really much clinical evidence. When it comes to stage 1, there is clinical evidence. At this point, you are getting exposed bone, but the patients are asymptomatic. So stage 1 will be a patient says, it doesn't bother me, it's not infected, but I noticed I have some exposed bone. By the time you get to stage 2, that's when you get both. Now you're having clinical exposed bone, and you're having infection and inflammation. And these patients, of course, are symptomatic. In stage 3 is really just a continuation of stage 2. So it's a little bit worse in the sense of stage 2. So you have exposed bone, you have an infected bone, and then you have one of the following that just makes it a little bit worse. What are the following things that makes it worse? You'll have the bone will not just extend through the alveolar bone, but it will get all the way down to the basal bone. So it will get down to the inferior border, or it will get all the way up to the maxillary sinus. It can also be accompanied by a pathologic fracture or an extra-oral fistula or an oral-anchial communication, oral-anchial fistula. So if you have any of those criteria, that would make something stage 3. Now, in terms of pathophysiology, so of course this is still a developing field, but in this position paper, they're just going to mention a couple of the different hypotheses, and in truth, it's probably some combination of all of these, but they list the following three. So is it bone remodeling inhibition? That seems to be certainly one of the primary causes, because we know antiresorptive medications affect the osteoclast pathway, and so they're preventing the bone turnover. And that certainly seems to play a key role, but maybe it's not the only role. The second is inflammation or infection, and that's a really important point because often we know MRNJ develops in sites after teeth have been extracted. And we're going to talk about this a little bit later, but it's worth pointing out. Often, when teeth, you're not extracting perfectly healthy teeth, right? Of course not. You're extracting teeth that have infection or inflammation. So perhaps it's the infection or the inflammation that's contributing to the development of MRONJ. And lastly, it's angiogenesis inhibition, because we also know these medications also do affect the blood supply. And what goes along with this third hypothesis is the fact that MRONJ is more common in the mandible and less common in the maxilla. And of course, the mandible is less vascular and the maxilla is more vascular. So anyway, so it's between these three different hypotheses as to the pathophysiology: bone remodeling inhibition, inflammation, infection, and angiogenesis inhibition. And like I said before, it's probably some combination of all three. Now, and also I should mention maybe the patient has some acquired or innate immune dysfunction, and that goes along with the fact that this is more prevalent in patients with diabetes, is more prevalent in patients who are on chronic steroids, etc., etc. So again, so even there's a fourth pathophysiology, and it's probably some combination. Now, this is really important. Let's get into the numbers. I'm a big number guy, and I think when you're counseling your patients, to do them justice, when you're trying to discuss risks and benefits, it's really appropriate to know the numbers and discuss the numbers with them. So what are the numbers? What are the incidents? How frequently are we going to see this complication? And of course, we have to differentiate between MRONJ risk when it comes to cancer patients and when it comes to osteopenic or porotic patients. And of course, the reason for that is we know the dosage and the route of administration is quite different. When it comes to cancer patients, they're typically given a very high dose. They're given it through IM, intramuscular, or IV, and they're given it frequently. And when it comes to osteopenic or porotic patients, they're given it less frequently, usually just oral forms of oral bisphosphonates. But sometimes for osteopenic, they will give IM or IV, but in those cases, they're only going to do it once every 6 months or once a year and nothing more than that. And the dosage is so much smaller. So that's the whole reason why we differentiate. So what is the MRONJ risk when it comes to cancer patients? So again, they're going to point out that we have wide ranges of data reported in the literature. Now, that is to be expected. This is a really rare side effect or complication. And so when you have rare side effects, it's hard to get a great number. And that's why you're going to find a huge range reported in the literature. So that range tends to be somewhere between 0% and 18%. But that's pretty big. So they say generally those numbers cluster somewhere in the low single digits and around 5%. So that's the number I'm going to go with, because we can't, it's great to offer our patients numbers, but if we're going to give them ranges that would just confuse them, we got to give them a solid number. So 5% I think is a fair number. So the risk for MRONJ patients, MRONJ development in cancer patients is about 5%, which I would then equate to 1 in 20. When it comes to bisphosphonate for osteopenic patients, the risk is obviously much lower. So here's the numbers for that. It's about 100 times lower. So it's about 0.05%, which means 5 in 10,000 or 1 in 2,000. So again, it was 1 in 20 when it was a cancer patient, and it was 1 in 2,000 when it was an osteoporotic patient. So about 100 times less common. Now, they do mention something. They said, until now, we've just been talking about the risk of, of MRONJ developing in those subsets of populations, but we didn't stratify about the preceding local factors such as dental alveolar extractions. And tooth extraction is the predisposing event about 75% of the time. So we have to take that into account. So most providers, and they say it really nicely here, most providers and patients want an answer to the following clinical question. Among patients exposed to antiresorptive medications, what is the risk of developing MRONJ following tooth extraction? Right? Of course, that's the question we all want to know. We don't want to just know what's the risk of developing MRONJ, without an inciting event. We want to know, if we extract this tooth, what's the chance we're going to develop MRONJ? So that's a much more important clinical question. And the numbers for that, again, we're given ranges, so we're going to do our best. But when it comes to osteoporosis osteoporotic patients, it's somewhere between 0% and 0.1%. So I'm going to go with the zero point 0.1. I think that's a good number. Zero point 0.1 equates to 1 in 1,000. So the chance of an osteoporotic patient developing MRONJ with having an extraction, 1 in 1,000, which really I would counsel my patients. It's a really rare risk, and that means 999 times out of 1,000 there was no MRONJ, and only once out of 1,000 there is MRONJ. When it comes to cancer, the risk goes up substantially. So the range is somewhere between 2% and 15%. When I counsel my patients, I usually stay towards the higher side of the range. So I'm going to report to them somewhere around 15%, which equates to about 1 in 6. So if an osteoporotic patient, it's 1 in 1,000, and if it's a cancer patient, it's 1 in 6. So as you can appreciate, it's substantially higher of a risk. And that's great. So again, I just want to point out none of these numbers are new. They're all in the 2014 paper, but just very important just to review and always be aware of the numbers. They do mention that it does not appear, MRONJ is not appearing in kids in under age of 24. Now that may be for a few reasons, right? Kids are not often exposed to these medications. If you think about what the indications for these medications are, cancer or osteoporosis, that's not very prevalent amongst children. But of course, there are other rare indications for these medications, including osteogenesis imperfecta. And when you look at subsets and studies on those patients, they're not developing MRONJ. Now, it may be there's just not a big N, but it's also likely that the age contributes. And when you go back to the pathophysiology and the angiogenesis and the immune response, it makes sense that children who have better vascular supply and better immune systems would be less likely to develop MRONJ. So we're not seeing MRONJ in children under 24. All right, moving on. Now that we've talked about the numbers, this is an important point. Based on those numbers, do we recommend a drug holiday or not? If you remember back in 2014, it was recommended. We said for oral bisphosphonates for osteoporotic patients who are taking it for 4 years or longer, we said, the evidence wasn't really great to support it, but it seems to make sense. So we did recommend a 2-month drug holiday prior to extracting a tooth. Now, in this 2022 update, they said, when we look back at the numbers, there's not a lot of evidence to support it. And you can make a counter argument that by discontinuing these medications, or even just by alerting the patients and scaring them, they may be discontinuing the medications for a prolonged amount of time, and then may increase their risk of fractures. And so when it came to this 2022 update, the 6 authors were evenly split between offering the drug holiday on a case-by-case basis or by not recommending it, because the concern is that suspending the anti-resorptive therapy may outweigh the benefit. And so basically they leave off and they say it's controversial, and they don't give you any recommendation, plus or minus. Special concern should be made about Prolia. So until now, I've been talking mostly about bisphosphonates, and I include Prolia and Xgeva, the denosumab, because for all intents and purposes, it acts the same when it comes to the numbers. I didn't specifically mention them before, but the numbers were very similar when it came to denosumab versus the other bisphosphonates in terms of the risk. But there's one key difference which really separates denosumab, and that is just how the half-life. Bisphosphonates, the half-life is 10 years, 20 years, so it will stay in the person's body for years and years to come, whereas denosumab only lasts in the body for 6 months. And so when it comes to denosumab, and when I mean that, I'm talking about the trade names Prolia and Xgeva, when it comes to those medications, actually a drug holiday is fairly sensible. And so the paper does say that in that case, if a patient's on Prolia, it does make sense to discontinue it for a few months before. If the half-life is 6 months, they say, okay, so you should stop it for 3 to 4 months, have the extraction, and then wait another 2 months afterwards, and that should be enough to minimize the risk when it comes to Prolia or Xgeva. All right. Now, in terms of the MRONJ prevention strategies, putting it all together based on what we know about the risks, when it comes to non-malignant disease, meaning we're talking about osteoporosis or osteopenia, in that population, what's the incidence? It's about 1 in 1,000, so it's really rare. So what would you expect the strategy to be? Basically, don't change anything. It's a really rare occurrence, so no alteration of operative plan is indicated. Just proceed as normal. If a patient needs a tooth out, you tell them there's a 1 in 1,000 chance you could develop MRONJ. It's not very likely. 999 times out of 1,000, you'll be fine. And so basically, you don't need to really do much else. In terms of the drug holiday, it's controversial. You can try to use other confounding variables or other things that may influence your decision. Is the patient on chemo, steroids? Is there any angiogenesis? Is there any other things that may lean you towards discontinuing the meds for just 2 months for a drug holiday or not? And then when it comes to malignant disease, cancer patients, multiple myeloma, who are getting the higher dose of IV or IM bisphosphonates, what are the management strategies when it comes to that population? So in that population, we're saying avoid dental alveolar surgery if possible, and that makes sense because we know the incidence of developing MRONJ with an extraction is 1 in 6. That's a fairly high risk. So avoid dental alveolar surgery, consider root retention techniques to avoid extractions, and dental implants are contraindicated. And that's the guidelines. And I don't necessarily disagree with those guidelines, but at the very end, I'll share my 2 cents about this root retention technique. That part strikes me as a little bit outdated because, well, I guess now's a good time as well to talk about it. Well, as good time as any to talk about it. So this, I think, is a little bit outdated, and there's always been a fear of extracting teeth in this population. But I would say that whether you extract the tooth or not, they may develop MRONJ, and it has to do with what we discussed earlier when we understand the pathophysiology. Is it the inflammation and the infection, or is it the extraction, or is it both? And so if a patient has a PAP or has significant periodontal disease, and they have a chronic source of infection, that's just as bad for them as the extraction. And by amputating the root, are you really expecting healthy bone to grow over an infected root? Right? We know when we do coronectomies for third molars, we can only do coronectomies if there's no PAP, if there's no infection. It would never work if there's a source of infection. No, we're not expecting bone to grow over an infected root. That wouldn't happen. So I'm not sure I quite agree with this. I think this part is still a little bit dated. And when we get to treatment, we're going to talk about sequestrectomy. We're seeing that more and more actually sequestrectomy is beneficial, and we're not considering it a last resort like we used to. And so I think actually in the future, maybe I'm getting ahead of myself, but maybe in the 2032 position paper, they're going to say, well, let's get rid of this root retention technique. All right, let's move on a little bit. That's my own 2 cents. Bone turnover markers. So this was a hot idea. It turned out that actually there's not a lot of research to support it. We were trying to find something like if we can have patients take a blood sample and we can get the CTX and we could try to identify their bone turnover levels. Maybe we can correlate that with the risk of developing MRONJ, and maybe we could better counsel our patients. But again, we found out that these markers were not very reliable, and so they're not recommended. In terms of prevention strategies, when it comes to cancer patients, it's always a good idea to see the patients before they begin it, before they start these new bisphosphonate medications, and then you extract all hopeless teeth. That makes sense. That hasn't changed. If you do extract the teeth prior to beginning one of these medications, how long should you wait before starting these medications? That's a good question, and the answer is until the surgical sites have mucosalized. What does that translate into dates and times? That's typically between 2 and 3 weeks, until the gingiva has covered the extraction site and the surgical site is fully mucosalized, which is about 2 or 3 weeks. But the statement actually, if you read it carefully, also says, or until there is adequate osseous healing. Now, I'm a little bit vague about what that means. I suspect osseous healing is a process, right? We know. I would guess my interpretation will be full osseous healing occurs somewhere around 4 months, right? Extrapolating from bone graft, usually we wait 4 months for the bone graft to incorporate. Adequate osseous healing, not necessarily as full, so I would say it's somewhere around 4 to 6 weeks, like the time period that we take a patient when they're recovering from a jaw fracture or for an induced fracture like orthognathic patients. Usually 4 to 6 weeks later, we assume there's adequate osseous healing. So depending on how long you can afford to wait, you wait, right? If the patient has multiple myeloma and you can't afford to wait more than 2 to 3 weeks, I think that's appropriate. And if you could afford to wait 4 to 6 weeks, then of course that would be a little bit safer. But of course it depends. This is a conversation you're going to be having with the endocrinologist or the oncologist, and you're trying to decide how long the patient can afford to wait. Now, I do think the paper does go out of its way, and this is a little bit different from previous position papers, just to emphasize the good that comes from these medications. And they go out of their way and they're talking about this. And I think that's an important point. They're saying hip fractures carry a significant morbidity, with only 40 to 60% of individuals recovering to their pre-fracture level of mobility and the ability to perform instrumental activities of daily living. So they're saying these medications have a great benefit, and we shouldn't get sidetracked with this extensive discussion about this rare occurrence of an adverse event, and by no means are we trying to scare our patients or dissuade our patients from taking these medications, because by doing so, if hip fractures all of a sudden start going up, say, well, then the morbidity and the mortality that comes from hip fractures significantly outweigh MRONJ. And so they said that there was a few year period where fractures started going up. Now, of course, we're not sure what caused that to go up, but one theory is, well, maybe it's because we started talking about MRONJ so much so that patients started getting scared. They started going to the doctors and saying, "Hey, take me off this medicine, switch me to a different medicine," and then all of a sudden we saw fractures go up. So the position paper goes out of its way to really emphasize the benefits of these medications outweigh the risk, and that's important to always put that in perspective. Um, just checking. I think that's it. There's really a lot to talk about. There was a lot to talk about. I'm going to just quickly summarize it. So, what did I get out of this position? Oh, sorry. There's actually a whole the treatment, the management. All right, so I'm going to very briefly just talk about that. In the past, when it came to treatment and management of MRONJ, we always thought surgery was like a very reserved for very refractory cases, and it was always very last ditch effort. And we tried to do non-operative therapy as long as possible, and that consisted of things like Paradex and antibiotics and just watching and waiting. And more over the last few years, papers have been coming out showing that early surgery, specifically sequestrectomy and debridement, actually led to clinical resolution. And we started changing our opinions about surgical intervention. Right? Initially, we thought, hey, anytime you go and do surgery, you're just going to make MRONJ worse. And whatever the margins of the old MRONJ is now going to be even bigger. When you do a debridement, when you do a sequestrectomy, the margins used to be here. Now the margins are even bigger. You just made it worse. And so we were terrified of surgery. But now actually all the papers and a lot of data is coming out showing surgery is leading to resolution, specifically when patients have sequestrums ready to shell out. When they're at that stage, leaving that sequestrum, and just treating the patients indefinitely with antibiotics to prevent infection, that's not doing them any service. You have to shell out and remove the necrotic bone so that the body can finally get some resolution. And so there isn't that is changing a little bit, and this position paper reflects that. And they mention that surgery, even for stage 1, shows better clinical resolution. And so, like I was saying before, I suspect that will influence even this idea of avoiding extraction. Because if a patient truly needs an extraction, if there is a PAP, if there is infection, if there is inflammation, leaving that tooth in and just trying to cut off and amputate it and bury the roots, I don't suspect that would be very effective. Maybe in the future we'll reconsider that. But anyway, so I think that's pretty much it for the paper. I want to review it because I know we talked about a lot. We talked about the definition and the staging. We talked about some of the key differences with this paper from previous papers. And the differences were that the drug holiday now is controversial. Bisphosphonates are good. We should not scare our patients from taking them. And when it comes to treatment, surgery, specifically early surgery, is very effective, and we shouldn't just consider it like for very refractory cases. Rather, we should consider it even in stage 1 cases, because we see that they are very effective at leading to clinical resolution. All right, guys, and that's it. I hope you guys have a great day. Bye bye.